Thank you for joining me here today. My name is Alaysa Thygersen, and I will be presenting the scholarly project, Prediabetes, Implementing an Algorithm into Practice. First, I would like to thank my committee support, Dr. Joanne Kern, my chairperson, and those at the Catherine McAuley School of Nursing and College of Health Professionals, as well as my fellow colleagues. My community members that I'd like to thank are Dr. John Pedrati and the statistician, Dr. Mark Pauls. Prediabetes is a progressively elevated blood glucose process that impacts Americans with many unaware of their healthcare condition. Research has shown that over a period of time of merely 5 years, it can develop into type 2 diabetes, a chronic disease. Primary care is a setting to enable prevention of morbid disease and reduce mortality related to dysglycemia. Quality improvement projects are utilized for doctoral nursing projects to provide changes that will improve patient outcomes. Therefore, a quality improvement project incorporating the CDC and ADA collaborative prediabetes risk test into a primary care practice was conducted. The purpose of this scholarly project is to implement and evaluate an evidence-based pre-diabetic risk screening questionnaire into a single provider family practice clinical setting that does not have a standardized pre-diabetic screening process for non-pregnant adults. The aim is to increase asymptomatic pre-diabetic screening among non-pregnant adults without a personal history of diabetes. The image on the right is the prediabetes risk test that was utilized. This is a publicly available questionnaire developed by the CDC and ADA to screen non-pregnant adults for their individual risk of prediabetes. The form was implemented into a primary care practice on February 1st, 2020. It is a simple 7-item questionnaire with modifiable and non-modifiable items. A score of 5 or higher indicates an increased risk for prediabetes. The research question guiding the inquiry is: in a single provider family practice setting, what is the impact of utilizing a pre-diabetic risk algorithm on hemoglobin A1C screening compared to not having a standardized process? Diabetes is extremely costly to the U.S. financial budget. In 2017, it was over $300 billion, accounting for 1 in 4 healthcare dollars. In fact, it is such a large national concern that there are diabetic programs in every metropolitan area across the U.S. In 1993, the ADA launched the first prediabetes risk test. The risk test was adapted through the rigor of research used and published and validated using data from the CDC. In 1997, the World Health Organization agreed, and it became a global health concern. It wasn't until 2010 that hemoglobin A1C was deemed a definitive diagnostic tool for both prediabetes and type 2 diabetes. Today, prediabetes is diagnostically defined as any of the following: a laboratory fasting blood glucose of 100 to 125, hemoglobin A1C of 5.7 to 6.4, and an oral glucose tolerance test of 140 to 199. According to rigorous research, 1 in 3 Americans are pre-diabetic, with only 10% being aware of their diagnosis and the risk of progression. In healthcare, diabetes is costly. As I stated, it cost the U.S. approximately $327 billion in 2017 and estimated to cost the individual patient over $16,000 annually. For the advanced practice nurse, it is vital to routinely implement screening for asymptomatic prediabetes to prevent or delay the onset of type 2 diabetes. Research has shown that there is still a gap in screening of even with the availability of hemoglobin A1C. The literature revealed 3 dominant themes that served as a potential hindrance to pre-diabetic awareness, potentially aiding in late asymptomatic or symptomatic detection. The first theme is surrounding prediabetes screening. Early identification of prediabetes requires asymptomatic screening. National screening guidelines utilized among most of the research was either the ADA or the USPSTF. Laboratory dysglycemia screening was most commonly conducted with the hemoglobin A1C test. As you can see in the photo, the values for prediabetes versus type 2 diabetes is available on the left. Prediabetes screening is recommended to be conducted every 3 years. The research resulted that providers frequently did not adhere to pre-diabetic screening guidelines and missed opportunities in screening up to 80% of the time in adult patients. The research illuminated that the frequency of missed screening opportunities necessitates for a standardized asymptomatic screening process. When a standardized pre-diabetic screening practice was conducted, the proportion of screened individuals for prediabetes was greater than 50% of the time, validating the requisite to implement a standardized pre-diabetic screening policy into practice. The second theme is provider perspectives surrounding prediabetes. Providers have mixed attitudes and beliefs surrounding prediabetes. Positive attitudes towards prediabetes screening was associated with being female, being of a minority, practicing for fewer years, and overall being younger. Barriers for screening included insufficient time in appointments and decreased staffing. Providers disagree that prediabetes will develop into type 2 diabetes. The division in prediabetic perspectives aids in the late surveillance and awareness of prediabetes. Lastly, a resonating theme arose regarding provider knowledge deficit. 1/3 of providers were unfamiliar with the national guidelines for prediabetes screening. The most common guideline myths are set by the ADA. More than 50% of providers were not comfortable with prediabetes screening and management. Together, these three themes provided gravity in the hindrance of patient care and enhanced the pattern regarding missed or late detection of prediabetes. Prediabetes is a blood glucose level that is above normal yet does not meet the criteria for diabetes. The term dysglycemia is a two-part word. The first part is dys, the prefix meaning abnormal or impaired. The second part of the term is glycemia. It is a word to describe the presence of sugar in the blood. The term provider is someone who provides a particular type of service. In this case, it is a healthcare provider. The term knowledge is a noun, and it is a condition of being aware through gained experience. Knowledge is obtained through study or interactions from one or multiple individuals. And the term screen is also another noun, a process for examining the individual, in this case for their individual risk of disease. The theoretical framework for this research project was the knowledge to action model. Evidence-based practice is continually progressing to ensure high quality care, to provide and to improve patient outcomes while diminishing potential harm. However, the transfer of research into practice is not consistent, delayed, or unidentified. The ultimate goal of the KTA process is to enhance the health status of the individual or the group. The KTA process is divided into two concepts: knowledge creation and the action cycle. The two concepts can be done separately or consist of an ideal phase that are complex, fluid, and may intermingle. Knowledge creation is a funnel where the gathering of the primary sources are being dwindled through a filtering process to a finite and manageable amount of content. This knowledge inquiry was the literature review represented here today. The literature review highlighted the insufficiency of the standardized screening and knowledge regarding prediabetes, thus resulting in the importance of disseminating standardized algorithms into practice today. The cycle action is the application of the empirically derived knowledge into effect through a series of phases. That was all completed through the research process. This project was a quantitative exploratory design of a quality improvement project through a retrospective EMR review, thus ensuring that no engagement was with the participants. During the patient encounter, the provider documented the prediabetes risk test was completed, the patient's individual score, and if warranted, ordered a hemoglobin A1C test. The clinical setting is a single provider primary care clinic in the western region of the United States. Participants were selected through consecutive sampling over a fixed period of time of November 1st, 2020 through May 31st, 2021. Only limited demographic data was extracted pertaining to gender and age. Due to the design of the scholarly project being an EMR, there's no recruitment nor incentivization for the study. The inclusion criteria was 18 to 89 years of age, seen in the clinic during a fixed period of time, and the exclusionary criteria is anything that fell outside of those age ranges, as well as being pregnant, having type 2 diabetes or type 1 diabetes, and prediabetes. The resources for the scholarly project were the clinical site, time, supplies, and funding. I am the sole researcher and funder of the project and am not employed at the clinical site. Therefore, I utilized my personal vehicle to visit the clinic and cellular device to ensure quality improvement project was being conducted, as well as when I had to travel to the clinic to collect the data. Maryville University provided the school's statistician as an ancillary service for this research project. So the project's total cost was approximately $381.84. This was a retrospective EMR study. There's no foreseeable risks for physical, psychological, social, economic, or legal concerns that will result from this project. However, minimal risks of a breach of privacy or confidentiality can occur. The individuals were kept anonymous and were maintained throughout the EMR review through providing each chart review with a serial number in the data collection sheet. Lastly, the participants have a minimal risk of deception as the quality improvement project was implemented for the purpose of a retrospective EMR review. However, there are minimal risks, and those risks did not outweigh the benefits of helping the patient population as a whole. The data collected was recorded on a data collection sheet via nominal coding. All potential participant identifiers were removed for the intensity of the research, and instead each EMR was assigned a number, as I stated previously. The variables collected were yes, no, and demographic information with specific nominal coding. The coding allowed for a seamless transition into utilizing the statistical program called SPSS software and the Microsoft Excel software for the graphs and imagery that we will see next. A total of 264 charts were reviewed during the 7-month period. 104 were excluded due to meeting exclusionary criteria. 160 met inclusive criteria, 80 pre-implementation, and 80 post-implementation. The Z test for the difference of two proportions determined there is a significant difference in hemoglobin A1C screening in the pre-implementation and post-implementation groups. The p-value is less than the significance of 0.05. There is sufficient information to suggest an increase in the ratio from pre to post-implementation. The achieved power of the study was 0.9554, which is considered medium in strength to evaluate the impact of a prediabetes risk screening test into a primary care practice setting on hemoglobin A1C orders. This graph represents the impact of implementing the prediabetes risk screening test algorithm on hemoglobin A1C orders, increasing from 11 pre to 29 post over an equal sample size with both groups equaling 80. The graph on the left displays the demographic characteristics of each categorical age in the two groups, pre and post. The categorical variables of age were extrapolated in the two groups. The age ranges matched the prediabetes risk screening algorithm age categories. Therefore, a mean age value was not able to be determined. The demographic characteristics of gender are in the right graph. The pre-implementation group consisted of 60% male and 40% female, and the post-implementation was very similar with 54% male, 46% female. The two study groups were equal in size of 80. The table results in the frequency of, the graph here results in the frequency of hemoglobin A1C among the age categories, displaying that hemoglobin A1C orders in the age ranges 18 to 49 increased using the risk test nearly 5 times the pre-implementation group, and the age ranges 60 to 89 nearly 3 times the pre-implementation group. The significance of the risk test increased hemoglobin A1C overall nearly 3 times the pre-implementation group. The pre-diabetic risk group the pre-diabetic risk test that was utilized in the post-implementation group, of those that were used to had documentation of proof that the prediabetes risk test was utilized, those that screened positively were 72.5% of the time. So out of the 40 individuals, 72.5% of them screened of being positive of being high risk for prediabetes. The impact increased hemoglobin A1C screening 5 times for under 50 years of age, and increased hemoglobin A1C 3 times for individuals 60 plus years of age. This study was conducted, the first limitation was that this study was conducted during the COVID pandemic. Therefore, if the pandemic was not occurring, we may have had more individuals in the post-implementation group, and potentially the pre-implementation group as well. Using an EMR retrospective design methodology to evaluate the phenomenon relies heavily on proper documentation collection. The post-implementation group resulted in simply half of all eligible charts being documented with the utilization of the prediabetes risk test, inferring the remaining half of participants were missed opportunities for assessing prediabetic risk and the potential need for hemoglobin A1C screening. Additionally, racial demographics were not evaluated within this research, and we know that that certain ethnic groups are at higher risk of diabetes overall. And lastly, hemoglobin A1C results were not reviewed to determine if by screening with the hemoglobin A1C, did we actually catch more individuals with being diagnosed with prediabetes. Incorporating the prediabetes risk test into practice can be easily accomplished, as it is a free tool available online through the ADA or CDC via PDF or electronically. In this study, the clinician completed the risk test with the patient. However, clinical settings not interested in having providers complete the 7-item questionnaire due to time constraints or staffing may provide it directly to the patient to complete while awaiting their appointment, and this just increases awareness even more. Additionally, it increases awareness for the concern of prediabetes, as previous research has outlined that 90% of Americans are unaware of the pre-diabetic diagnosis. Lastly, this research aligns with the current national guidelines announced by the USPSTF August 2021 that lowered the age of pre-diabetic screening to age 35, which was previously, when this was implemented, the age 40. The provider can utilize this research into policymaking, which can result in cultivating improvements in patient-centered care overall. The results of the data analysis justifies the need for implementing a prediabetes risk test for non-pregnant asymptomatic adults, particularly in a single provider primary care clinic. The scholarly project revealed that incorporating the prediabetes risk test nearly tripled hemoglobin A1C screening without roughly two-thirds of individuals, with roughly two-thirds of individuals screened being at risk for prediabetes. The sustainability of the prediabetes risk test is a multifaceted approach of the healthcare team in establishing policy, encouraging routine screening and documentation, and providing the documentation can flow into the next encounter, which may have been part of the issue with this implementation project. Okay. If you have, thank you very much for viewing. If you have any questions, feel free to contact me at my email here. My name again is Alaysa Thygersen. These are my references. And again, thank you.